Hello, my name is Lauren Lowe, and I'm an internal medicine intern at Santa Clara Valley Medical Center. I am presenting a clinical vignette on using octreotide to treat bronchorrhea that is not caused by pulmonary malignancy. Bronchorrhea is a symptom often managed by hospice and palliative care physicians in the setting of non-small cell lung cancer and pulmonary metastases. Other causes of bronchorrhea besides pulmonary malignancy include tuberculosis, bronchiectasis, bronchitis, and asthma. We present a patient who did not have any of the aforementioned diseases but had bronchorrhea that was refractory to first-line treatment. This is a 38-year-old female with pertinent history of anti-NMDA receptor encephalitis complicated by dysautonomia with resultant bradycardia requiring a permanent pacemaker, as well as altered mental status requiring tracheostomy and mechanical ventilation. The patient presented with septic shock from pyelonephritis, bacteremia, and pneumonia, requiring admission to the medical intensive care unit. During this time, she had purulent respiratory secretions that resolved after appropriate antibiotic treatment. However, the patient continued to have copious, clear, thin respiratory secretions averaging 250 cc's per day, requiring tracheal suctioning every 5 to 10 minutes. She was trialed on glycopyrrolate, scopolamine patches, botulinum toxin injections to bilateral masseters, parotid glands, and submandibular glands, intrapulmonary percussive ventilation with nebulized saline, nebulized acetylcysteine, and nebulized albuterol plus ipratropium. However, none of these interventions significantly decreased her bronchorrhea. We found a publication by Hudson et al. That effectively used octreotide to treat bronchorrhea in patients with lung adenocarcinoma. We started continuous IV octreotide as suggested in the paper at 25 micrograms per hour, which resulted in subjective improvement in suctioning requirement by the nursing staff. After 3 days, suctioning requirements improved significantly, so the IV octreotide was transitioned to subcutaneous octreotide injections of 200 micrograms twice daily. However, this dose did not adequately control her bronchorrhea, so we increased to 200 micrograms 3 times per day, which decreased her secretions to less than 50 cc's per day and decreased suctioning frequency to once every 1 to 2 hours. The proposed pathophysiology of bronchorrhea in lung cancer is through increased secretion of chloride and bicarbonate by bronchial epithelial cells, which is mediated by secretin. Octreotide is effective in treating bronchorrhea because it inhibits secretion of secretin. Current literature documents the efficacy of octreotide in treating bronchorrhea in the setting of non-small cell lung cancer, but our case demonstrates that octreotide can be used to treat excessive pulmonary secretions even in the absence of pulmonary malignancy. So if your patient has bronchorrhea that is not responsive to conventional first-line treatments, such as antimuscarinics, consider starting continuous intravenous octreotide or subcutaneous octreotide injections. Thank you for your time.